A 24-year-old male presented with chest pain after minor trauma. I'm showing you his chest radiograph. Describe the findings.
Let's see. Yes. The chest radiograph shows no focal lung abnormality and no rib fracture or pneumothorax is seen. However, there is bilateral inferior rib notching involving the 3rd to 8th ribs. The aortic knuckle is not well seen, but there is no other mediastinal contour abnormality, and the heart is of normal size. No previous cardiac surgery signs are visible.
What is the most likely diagnosis, and what clinical check would you perform?
The most likely diagnosis is coarctation of the aorta. Clinically, we should check and compare blood pressures in both arms, and also compare the arms with the legs to evaluate for radiofemoral delay and lower limb hypotension.
What are the causes of inferior rib notching?
Inferior rib notching is typically arterial, venous, or neurogenic. Arterial causes include coarctation of the aorta or subclavian obstruction after a Blalock-Taussig shunt. Venous causes include superior vena cava obstruction. Neurogenic causes include neurofibromatosis. Arteriovenous malformations are another differential.
What are the causes of superior rib notching?
Superior rib notching can be caused by connective tissue disorders like rheumatoid arthritis, scleroderma, or systemic lupus erythematosus. It can also be seen in hyperparathyroidism, neurofibromatosis, Marfan syndrome, and restrictive lung disease.
I am displaying an angiogram of the thoracic aorta. Describe the findings.
As seen in this angiogram, there is a focal postductal stenosis of the descending thoracic aorta with poststenotic dilatation.
Describe the classification of coarctation of the aorta.
Coarctation is classified as preductal or postductal. Preductal is preductal with a long hypoplastic narrowed segment, presenting in infancy with congestive heart failure. Postductal consists of a short narrowed segment immediately distal to the ligamentum arteriosum, presenting in later childhood with hypertension, differential arm-leg blood pressures, or a murmur as just demonstrated in the angiogram.
How would you manage this patient as a radiologist?
I would compare the chest radiograph with prior films to evaluate for any signs of cardiomegaly or progressive rib notching. I would communicate the finding of bilateral inferior rib notching immediately to the referring clinician due to the high association with systemic hypertension and aortic dissection. I would recommend a contrast-enhanced CT angiography, CTA, or MR angiography, MRA, of the chest to visualize the coarctation segment, measure the stenosis, and evaluate for collateral vessels. I would also refer the patient to cardiology and cardiothoracic surgery for evaluation and treatment planning.